All right, welcome back. Another podcast here, but as always, I've got to bring in the expert, as it relates to really what's the new frontier in cancer care, and that's the intratumoral. That's going right to the tumor, bypassing the systemic to tumor approach, and basically empowering the immune system to do its job by taking your action against the tumor. And there's no other person to talk to other than the founder of the Williams Cancer Institute, of which I gladly work with, and that's Dr. Jason Williams. Jason, welcome to the podcast again, my friend.
Thank you, Nathan. Appreciate it. Good to see you.
You know, when you look at innovators, and I think I've said this before, maybe it's just been personally with you, there are innovators and there are doctors, and it's rare that you see the two together. And I think you've said something to the point that, you know, what you really do is you really work to innovate and create, but you just, do doctoring because it's fun. You enjoy it. That's kind of a good summary of what you've said before. Is that right?
Yeah, I guess that's correct. Yeah, I mean, obviously, we're just trying to help people. We want to get rid of cancer, want to make people better, and do whatever it takes to do that.
Yeah, and so innovation is that word that right now that we need more of it in medicine. We need more of it in cancer care, and because we've been locked in a paradigm in medicine for the last 100+ years or so, where it's been that systemic route. The highway has been the blood way. It's been the systemic delivery to get to the tumor. But you brought forward a new idea, not just yesterday, but actually a while ago. How long have you and how long has the Williams Cancer Institute been doing intratumoral targeting?
Well,
how long have you been doing that?
I mean, technically, we've been injecting tumors for over 20-something years. I mean, it's starting with doing ablations and then putting, some medications in with it. The idea was that, hey, you're there, you're ablating, maybe you could add a little medication. I mean, I think I applied for the first patent of combined ablation and pharmaceutical agents. That was back in 2004. So we were, doing it back then. Obviously, things have advanced, and there's lots of options of things that you can inject. I mean, when you think of all the things that you can, when you're accessing a tumor, you think of all the things that you can put into it. Obviously, we've been discussing a lot now. We're injecting this vitamin C directly in tumors. I mean, look, you can inject, ivermectin. You can inject tons of things, right? I mean, everything you could ever imagine. Put it all right in the tumor. The chemotherapies right in the tumor, and see what it does. That makes a lot more sense than putting it all over the body first and expecting it to get there. Put it in the tumor first and see what happens and change that environment. And so, that's I don't know if that's the way we do it. To me, it seemed very obvious, but I guess everybody else that didn't seem very obvious.
It's really interesting when you say that, because when you're doing something and you present it to somebody, then they go, I never would have thought of that. And you go, what? It just seems obvious. And,
yeah.
And I think that's just what separates, people like you, and really what separates Williams Cancer Institute from maybe other institutions out there, because your approach that you really pioneered, and I mean, think about that, 20 years in cancer care, that's quite a length of time. That's not short.
Yeah.
That's innovation, where a lot of technological advancements can really occur through that 20 years.
Yeah.
And what you're now starting to see is this basically come into the public consciousness more and more.
Yeah.
And so that it's not I don't even know what this is. I've never heard of it. And so there's going to be, more awareness, more practices, more doctors that take this on. And so then there's followers and there's copycats. But I think it's always important to understand where this concept originated, where it's really been pioneered. But it's not something that you just rest on the laurels of the past, right? You continue to innovate to find how this can make patients with cancer better.
Yeah. Yeah, and there's so many possibilities of things. Obviously, we're looking at immunotherapies. There's numerous combinations that you can inject. Look at all these other drugs and looking at things that we can do. And gosh, we just have such it's kind of crazy. We have so many things that we can inject into tumors that you could get by with that aren't going to really cause problems for the patients, and yet that's just not really being done like in regular practice. Makes no sense.
Well, so here's a question of the obvious. Why do you think that is?
Everybody wanted to really look to, the systemic route. They wanted, it was giving the drugs intravenous, it was giving the drugs oral, and they thought that's the only way that you could like give it like from, a far distance, right? I guess you'd say to get to the tumor. And I don't know why they don't think of like, okay, maybe it'd make more sense to put the drug actually in the tumor. I don't know, but it doesn't. I mean, that seems common sense, right? I mean, you got a chemotherapy. No, let's not put it in tumor. Let's put it in all the normal tissues, right? Let's just spread it all around everywhere. That makes a lot more sense, right? I mean, that's what they're right. That's what they're doing. I mean, so I mean, like you're in the tumor. Look, we biopsy things. So, look, you want to give a chemotherapy, put a little chemotherapy in it, right? Then you could look. Where if you ask a person where you want your chemotherapy, you want it everywhere in your body, you want it in the tumor. Well, I think they want it in the tumor, right? That's what you want to kill. You don't want to kill the whole person. That's what.
And the tumor microenvironment, let alone trying to go through the body to get to the tumor. Most patients with tumors, that tumor microenvironment can create quite a bit of a buffer to keep the therapeutics out.
Yeah, they isolate themselves because, they get all these fibroblasts and things like that. And that's an environment you have to change as well. And, expecting to try to change it externally alone is really hard. I mean, yeah, sure, there's systemic approaches that will help you, but you should not rely solely on systemic. If you've got a tumor target, you should hit it with some stuff, right? You should be putting drugs in that tumor, not like just let it sit and give things everywhere else and expect it to get to that tumor. That makes no sense. I mean, you biopsied it, right? I mean, if they made the diagnosis, they biopsied. Look, that was the biopsy was your first chance right there. You could have treated it right then. You could have biopsied and then already started this patient's treatment at that moment. Even with simple things. I mean, even if you just injected some, NSAIDs, Toradol, or something like that, and there will you be better off than just biopsying and leaving it. Because now you just messed it up.
You can track local recurrence, send out circulating tumors.
Yeah, I mean, you stuck a needle in it. Now, boom! You made it mad, and so you need to sample these things. But you're going to sample it, treat it. I mean, I wouldn't be sticking a needle in something that I'm not going to also treat at the same time. I mean, that just makes no sense.
And let me tell you, that is so brilliant when you said that. And as excited as what we do with the intratumoral ablation and intratumoral immunotherapeutics, that concept of biopsy and treat at the same time, I actually look at that. I actually see that as next level. It makes so much sense.
Yeah, I mean, why should be sampling something and not taking the chance to at least put some stuff in it, right? I mean, look, okay, for the most part, I'll tell you by imaging, you probably know whether that's cancer or not. You probably, I mean, you're gonna be like in a 94-95% that's cancer. So you can inject some things. You don't have to get super aggressive. If it wasn't cancer, no harm, no foul, right? I mean, it's probably not gonna do anything. I mean, again, you're injecting small amount of drugs. It's not gonna be a big deal. But if it is cancer, right, you want to go ahead and get that rolling. You want to get the immune system seeing it. You got the chance to do that right there from the start, and that's the way it should be done.
Yeah, every opportunity is an opportunity missed to really activate the immune system. And so when you look at the innovation, it's not just the innovation of approach, and that's kind of what we've been touching on with the intratumoral versus the systemic. You've been touching a little bit on the intratumoral therapeutics, which, by the way, we have another podcast where Dr. Williams talked about the intratumoral immunotherapeutics and the vast array of things that can be used to activate the immune system there. But here I want to talk about it's really the synergy, because it's really interesting when you look at that concept of the abscopal effect in the literature. They do ablation and they do immunotherapy, but I've almost not seen a crossover where they're doing them together. And really what sets the foundation for that is the ablation. And there's a 2024 study, check out the show notes for the references, where in a murine mouse model, they actually used radiofrequency ablation in one arm and pulse electric field in another arm. So they didn't do the synergy, but they looked at the different ablations. But you're saying, no, we're looking at the innovation of the approaches, the therapeutics, but the synergism together.
Yeah. I mean, if you're in there, you're going to ablate a tumor. Obviously, you want to try to stimulate the immune system. So you want to do it the way that's going to maximize that. And then, you need to put some drugs in there with it to do that. I mean, gosh, just doing ablation and not putting medications in there, that's just, that's crazy. I mean, even some minimal stuff, right? I mean, I think, I know there's a lot going on right now where, like a lot of women are getting these, cryoablation of the breast, and that's a chance right there. Those patients, even though they're early stage, you should be injecting NSAIDs, you should be injecting, a CSF1R inhibitor. These are all things that have been shown to reduce the potential of the cancer spreading or recurrence, and you treat that, then you're going to save those people from becoming stage 4 patients later, right up front doing that. But if you just ablate it, no, I mean, then you're just doing the same type of thing as a lumpectomy, and you're still going to have that risk that there could be cancer elsewhere. So
there has to be that synergism together, because people talk about additive 1 + 1 = 2, but synergism is 1 + 1 = 10. So it's an exponential effect, and that's really, so you didn't just innovate with let's go to the tumor. You've continued to evolve in that innovation, basically because you're looking to do better and help more patients all the time. And that's where now these therapies are really starting to come together. And that's where we're starting to really see the effects in these patients. For example, recent story out there with Larry Boyer and stage 4 pancreatic cancer, now basically 2 years, no evidence of disease. Fox News story with I think it was a breast cancer patient, no evidence of disease, stage 4. So, I mean, this is real. It's not just theory. It's not just I hope. I mean, the team is really putting together under your leadership the next generation of cancer care.
Yeah. I mean, we should be, basically, with a patient who has potential cancer, the initial biopsy should be the starting treatment.
Yeah.
I mean, that's how it should be. I mean, that's what we need to change the whole way that cancer care is. But, that's, I don't know how we get it that way. We're trying. Obviously, we have our stuff trying to push things through the FDA, but we need to change the mindset of that. I don't know why, because they want to say, well, we need these, tons and tons of studies. Look, there's easy stuff that they can start doing. If they just added Toradol to inject in any biopsy, I mean, they're probably going to reduce some risk of metastasis right there.
But I really want to highlight your expertise on multiple areas here, but it's the different ablative techniques, again, highlighted in this 2024 study. Nothing to do with synergy, just the ablative techniques, because, when as it becomes more aware in the consciousness of the public, people are going to say, oh, we can do cryo, you don't have to do PEF. And then people are going to, I think, get confused about what cryo is. You see histotripsy on the scene. So, I mean, there's multiple types of ablative techniques. So I want to run through real quick and then just talk very specifically about 3 of them with you and let you really lead the show from there. But the PEF, the cryoablation, the irreversible electroporation, photodynamic therapy, high-intensity focused ultrasound, radiofrequency ablation, microwave ablation, laser interstitial thermal therapy, and then electrochemotherapy. But, it's the impact of the ablation on the immune system. And I want you to highlight your thoughts, because you've migrated through these.
Yeah.
You've done all of them, radiofrequency, cryo, and PEF.
Yeah.
Tell me, what's the best about each, and why has the Williams Cancer Institute clearly landed on PEF as the best immunostimulating ablative technique?
I think a pulse electric field is the one that, it kills some cancer in an immune stimulating way and seems to be fairly consistent. You're not looking to try to go blast a whole bunch of cancer. That's the misconception, right? That, people thinking like you want to go blast it all. That I think clearly in most situations is the best and the best chance to stimulate the immune response. The only other situation that I would say would be valid would be cryoablation. Well, cryoablation is obviously a little more available than pulse field. Pulse field is a pretty expensive technology. That really holds it back. But cryoablation is a little less expensive, and obviously the systems are a little more available. I think maybe in the situation of the early breast cancers, you could say, well, okay, cryo those lesions and inject. That might be still, a valid point. Getting rid of all that and injecting. But other than that, I think pulse field, is a way to go. That's the only time I would ever consider cryoablation would be limited breast cancer, like early stage, that I was going to freeze the entire lesion. Still going to inject some drugs to make it that I might do, because I can get just better coverage. I know I want to kill all that cancer at that time. But other situations, you're not trying to kill all the cancer because your problem is other cancer elsewhere. So when you're dealing with metastatic disease, pulse field clearly is a way to go. You're going to kill some cancer, stimulate the immune response, but you're trying to get a global systemic response.
Yeah, and I think that's a very, very good point, Jason, in that especially when you see that in cryo, they're trying to ablate the whole tumor, right?
Yeah.
They're not, like you said, you're trying to ablate part of the tumor, but what I see is these women that their whole breast is a solid rock.
Yeah.
And they try to basically ablate the whole breast in that instance.
That's going to be, yes.
You're using that local tumor and its destruction, not in and of itself that one some gain, but a global gain for the systemic activation of the immune system.
Yeah. But if you have a patient with a breast cancer that's locally a little more advanced, cryoablation would be the way you want to go on that. Then you got to go back towards the PEF and immune side, because that one's going to be problematic. The only ones that cryoablation would be these small little isolated lesions that you can freeze the entire thing. Okay, yeah, that's probably reasonable. You should still probably inject some drugs into it, at least to try to boost it, not just cryo it, but inject alone. That would be the only situation, though, that I would say. And they're doing a lot of that now. I think it's unfortunate, though. I hear, see it like online a lot. In the U.S. they're doing a lot of breast cryoablation, but clearly, they're missing a lot of opportunity because they're not injecting anything into it. So they're doing cryoablation, but just cryoablation alone. No drugs are used at all, and that's unfortunate. These people are going to be at higher risk going on to metastatic disease in the future. A lot of them are going to get by, but some are going to be at risk, and this is going to end up being a problem that could have been averted.
Is PEF for intratumoral cancer treatment, is that available in the U.S. as
It is.
Okay.
It is, but it's really tricky because insurance coverage is just terrible for it. Nobody really wants to do it a lot. I mean, there's no what the insurance companies will reimburse. I mean, very limited, and that just makes it where people don't want to do it, right? I mean, that's so I mean, the thing, the company, to me, it's a little surprising because they're like, oh well, reimbursement code is like pays like $10,000, but the needle's $10,000. So okay, so there you go, right? I mean, you don't make any money, so that doesn't excite hospital systems or anybody to use it, right? They're looking like, oh, well, yeah, the insurance company's going to pay us $10,000. We have to pay $10,000 for the needle, right. So there's no money, therefore, so they're not going to do it. They're going to say, hey, look, there's way more money. We cut you, we radiate you, chemo. That's a lot of money. That stuff will do. This other stuff, no, it's not. So they're gonna do what makes them money. They're not gonna do what.
And that's what I've seen in our patients at the Williams, is that their quality of life as a whole. Obviously, this is cancer that we're dealing with, so we have to recognize that cancer is cancer is cancer. But the quality of life of our patients is really quite high.
Yeah.
Compared to those that go through that basically gauntlet of surgery, chemo, and radiation on the hopes that they get to the other side. I mean, and then they try to heal. I've noticed our patients actually heal as they're going through treatment and their quality of life gets better.
Yeah. I mean, that's the goal, really. I mean, the way cancer care should be. Unfortunately, a lot of times we get patients who've already done a lot of things, made it a lot harder. I mean, if we got a patient like, brand new, that would be nice. But unfortunately, a lot of times they've already done stuff that's like made things challenging. But yeah, the goal would be to treat the cancer, but then simultaneously make the patient healthier. And that's what we can do. I mean, that's the way we can treat cancer. That's just not the way that is normally done. So what happens is patients are, obviously they're treated with lots of things that are detrimental to them, and then they come in a worse state. And then of course, then we have to try to overcome that, and then also try to treat the cancer. So we're actually fighting against the stuff that has been done to them that's now made it harder for us. I mean, if you give me a fresh diagnosed patient that has not done anything, that is a patient we can do a whole lot with. But you give me one who's done any other type of thing first, well, that's going to be more challenging.
Yeah, the compromised immune system to the body, it's just really hurt. And, in this 2024 article, I just wanted to kind of present some contrast between the PEF and the radiofrequency ablation, and then pull in some other research with cryo, because it's really interesting. So when you look at PEF versus radiofrequency ablation, the preservation of antigens with the ablation is really high in PEF versus radiofrequency ablation. That same is true with cryo, but help the listeners and viewers understand what that means. What are these antigens, and why are they important?
Yeah. So these dead pieces of tumor that the immune system would see, that depending on your ablative technology, so you think of it like pulse field, it's like, it's like electrocharge, but kills everything, but it kind of leaves it a little more like intact. Cryoablation freezes everything, kills it that way, and also leaves it kind of intact. Where is like radiofrequency microwave, well, that's cooking it and that's burning things down, so that's not leaving it intact. And so those pieces are not the same, and so by leaving more pieces of the tumor, killing it, but leaving them intact that the immune system could see, that's beneficial. And that's why the technologies like pulse field, I think, are the the best, and cryoablation, also, so close second. Cryoablation, the difference cryoablation is that, a lot of times when people are doing it, they're getting overzealous. I mean, cryoablation can allow you to do big volumes. You see them, doing these huge ice balls, and they're going to start damaging a lot of normal tissue. That's all. The pulse field, now most of the technology, or at least, the galvanized system is very small. So for you to go try to ablate big areas, that's just really hard. Just only ablating a centimeter at a time. I mean, so the system limits you. It makes it hard for you to actually get overzealous. so it actually is helping you by making that difficult to do. Because if you could ablate lots, you wouldn't want to ablate tons of tissue. You want to ablate just small areas.
Yeah, the goal is to target part of the tumor, preserve the healthy cells, preserve the production of these tumor-associated antigens from those dead cancer cells that you targeted part, so that the immune system can react to it. But you've actually worked with these companies that produce the pulse electric field to make it better, right? I mean, so you're getting.
I stay in contact with various companies, all of them, and I always tell them, like, I have no loyalty, allegiance to anybody except the patients in treating cancer, and so I don't care what you do. I don't care. I have no financial interest in any of them. I just try to give, like, I can tell you, like, you should do this, you should do that. You do whatever you want, but I'm going to try to help you, and it's free knowledge to them, and help to guide them, because hopefully they can make things better for patients. And I'll tell them, like, what we need to do, what we need to see, and things that they can improve on. And so, yeah, we do try to help them on those aspects. And so,
and then there's something called damage associated, damps. And when you look at it with the pulse electric field therapy, the cryo, and the radio frequency, I mean, the pulse electric field produces the most significant level of release of these damps.
That's
and
right.
Medicine, it's like going to an attorney. They write you a letter, and it's like, excuse me, I need a Google Translate for the legalese. And so sometimes in the medical world, we do the same thing. What is damps, and why is that relevant? That field produces the most significant amount.
Yeah, so you have these things they call damps, and you have things called PAMPs, damage associated, molecular patterns, and also pathogenic. These are things that basically are alerting the immune system. So, or sort of signals to the immune system, hey, there's a problem here, and you might need to look at this. And so that's what these things help release. And so that's the key of why they're more immune stimulating, is that they're producing these substances that are alerting the immune system to see it. And, that's some of the problem, because cancer obviously, tries to exclude the immune system. Cancer does everything to say, hey, I'm growing an immune system, don't see me. It's making these signals. In the perfect world for the cancer, it completely excludes the immune system, where the immune system doesn't see it at all, doesn't want to come in, has no reason to even mess with it. And also the cancer, super smart, we're going to block out like the entry points. We're not going to make roads for immune cells to us. We're going to get some fibrous stuff, and we're going to block us out. I mean, we're going to do all this stuff. That's what all the cancer does, right? It does all these things to ensure that it can grow without the problems. And so, these are things that you need to be able to kind of like shake up and knock down a little bit, so then the immune system can get around and see, oh, wait, there's a problem there. I was blocked out, but now I can see it. So, yeah, and so these signals, the immune system is looking for those signals to say, hey, it looks like there's something going on here. And that's what happens when you kill those things with some of these technology that allows that, like the PF, where then the immune system gets those signals and then says, okay, yeah, I'm coming in. I might need to look at this.
So the other aspect here is that it's the impact of the cytokines. And these cytokines are they're means of language of communication with the immune system. And we amongst our patients follow them every 2 to 3 weeks after treatment, because it's giving us some insight to the immune environment. So is the immune system triggering pro-tumorigenic activity or anti-tumorigenic?